Sure. So welcome everyone to day 3 track 10, where we'll be talking about supply chain modeling and forecast. And I just wanted to introduce the topics that we'll be talking about. And we'll get started with track 1 right now. And I'll move to the next presentation. So you can take it from here.
Okay, great. Yes, if you can move to the next slide, please. Okay, wonderful. So good morning, good afternoon, and good evening to everyone. My name is Dominique Swinkels, and I'm the Executive Manager for People That Deliver. I'm also joined today by Lisa Palmer, Public Health Manager at IQVIA, who we have worked with very closely to develop the workforce optimization tool, as well as its application in Zambia. And in the next few slides, she'll be able to introduce herself. So those of you who are not familiar with People That Deliver, we are a coalition of like-minded organizations that are working together to strengthen the capacity of the health supply chain workforce, while also promoting the professionalization of the supply chain role within the broader health system. As executive manager, I am constantly raising awareness around the importance of the supply chain, of the health supply chain, and working with these like-minded organizations to build a talent pool of supply chain management professionals globally and locally. When we started about 10 years ago, and this is, we're celebrating our 10 years anniversary this year, we found that the strategic function of the supply chain within the health systems is often not recognized. And this was coupled with health supply chain workforce lacking both technical and managerial competencies to perform optimally, as well as sort of the empowerment to make decisions that affect supply chain operations. And we now have seen quite a shift, and much progress has been made over the last 10 years. But more importantly, we're also working towards professionalization and embedding that into the workforce with very specific supply chain competencies in the health system. And we are today a global coalition that's focused on providing technical leadership in human resources for supply chain management. And I'm really excited today to talk to you about the People That Deliver workforce optimization tool. 2 years ago, my colleagues, Alexa Strader from PTD, as well as Stephen Hersano from IQVIA, had the opportunity to present the tool. And now today, we actually have the opportunity to present its application in Zambia. So next slide, please. So in 2018, when PTD published its theory of change, which helps to plan and prioritize workforce intervention that strengthen health supply chains, we showed that there is a theory of change that can that show sort of the necessary outcomes that must be in place to optimize workforce performance. And that is through skills, staffing, working conditions, and motivation. Today, we're talking about the very specific outcome of staffing. This workforce optimization tool was created to support countries in their staffing needs and created to estimate the staffing needs at each node of the health supply chain. The workforce optimization tool, or WOT, as we'd like to call it, really supports countries in better aligning their staffing with workload as well as performance goals. For instance, if we were looking at the current workload, we would ask ourselves, what is the right number of people needed in order to achieve the supply chain's performance goal? It is a tool that is different from any other tool that's currently used in our community. Next slide, please. This tool has a unique capability. In developing the tool, we actually looked at different types of calculators from past work, such as the WHO WISN, which was used by PTD in a workload exercise in Namibia in 2015. This tool, however, takes a step further and adds the ability to staff based not solely on demand, but also on supply chain performance, and the ability to minimize treatment gap. This optimization objective really is what is really new here to the tool. It has the potential to generate the kinds of information that donor implementing agencies have been asked to do for governments, And I believe that you'll see that throughout our presentation today. For some background, in 2018, we contracted IQVIA to help us develop this tool. Over a 2-year period with very distinct phases, we were able to develop it. We used EPI data from Pakistan and then very specific HIV/AIDS data from Nigeria to finally fully develop the tool. We see this very much as a very strategic tool, a tool that can be used for staffing plans using very strategic inputs, and a tool that really estimates staffing needs at each node of the supply chain, for instance, at the distribution center or a warehouse, or of course, a health facility. And so it really takes 3 major inputs and calculates a suggesting staffing plan. And as I said, it really helps to optimize through either supply chain performance or a specific treatment gap. Next slide, please. The objective of the optimization function is really to allow the user to link staffing to health outcomes and specific supply chain key performance indicators. The tool offers 3 ways to staff supply chains. First of all, ensure uninterrupted product flow based on demand, which is the standard. Then staff with priority given to facilities that have the largest treatment gap. And then staff with priority given to facilities that have the largest stock out rates. So those 3. Next slide, please. So before I pass it on to Elisa, I really wanted to mention that the WOT is data intensive and requires targeted data to be available that links with the research question. It really isn't a plug and chug tool, but an exercise that requires inputs from those who know how the supply chain is working strategically and tactically. For example, we need to match the consumption data we use to the resource question. There is preliminary work that needs to be done. First of all, we need to set the research question. Which question are we trying to answer regarding staffing and performance? This question will drive the project and determine the necessary data required. Then we need to look at consumption data. What is the volume of product moving through the supply chain? Consumption data should match and support the research question. And then it needs to analyze activities. What key activities are being modeled for, and is the duration dependent on volume? Activities should be classified into categories, such as pick, pack, delivery. There is some data intensity in this preliminary work, but we see it as being a good add-on for other projects. And so now I will pass it on to Elisa. Thank you very much.
Thank you, Dominique. So in July 2020, ZAMSA, the supply chain unit in Zambia, contacted People That Deliver after seeing a presentation of this tool. And they were interested in using the tool for an upcoming change in strategy. So on the screen here, we have a voice of the customer quote, but I'm just going to skip through that quickly with regards to time. So next slide. So when ZAMSA got in contact with People That Deliver, we spent a good portion of the project forming the research question. When they first reached out to us, the research question was not as clear as you're seeing it on the screen. And so through the thought partnership, we were able to further refine. And we would really advise that this step, the step of identifying the research question and refining the research question, be allotted enough time in the project scope to speak about with stakeholders. So in the case for ZAMSA, the organization was going to onboard 4 provincial hubs to be stock keeping hubs. So originally, these hubs were just cross-docking warehouses, and goods would flow from the central store through the cross-docking and get redistributed on trucks to go to the service delivery point. ZAMSA had seen that there was an opportunity for these 4 provincial hubs to start start stocking the most frequently ordered products. And this led to the question of, well, how many people should be staffed at these hubs given this uptake in stock management? And what is the right allocation of staff to be staffed? So should the staff that's going to hub 1 be all pickers, or what is the mix of the right staff? So with this research question in mind, we then looked at the consumption data. So we took the most frequently ordered products, which ZAMHSA had identified for us, and we looked at their consumption data for 2020. What we really wanted to see is what was the volume of product moving through the supply chain for these 14 products. Next slide. The next step after defining the research question and then identifying the consumption data is then to look at the activities and the time. And as Dominique mentioned, this can be a very data intensive process. And so for ZAMHSA, we had originally hoped to do shop floor walks at the central medical store and use that understanding to estimate what we would project to be the activities done in the hub warehouses. However, due to travel restrictions, we weren't able to do that. And so the estimates you see on the screen came from logistics director estimates based on his subject matter expertise knowledge of the central medical store and the layout of these 4 hubs. And so you'll see on the left, we have the activity, and then we categorize it by activity role. Later on, we'll share with you the link to look at the generic template of the tool. In that, you might see that the activity role follows the SCORE model. This is a customizable feature of the model that can be updated based on your specific supply chain needs. For each activity, we identified if that activity is quantity dependent or quantity independent, meaning does the amount of time taken to complete that activity change with the amount of product moving through. And then the activity time was given, and these major inputs are what the Excel model uses to do the math. So if we go to the next slide quickly, as Dominique mentioned, the use of this tool is to really run optimizations. And so the 2 levers to do that are to select your constraint. So you can run an unconstrained model or a constrained model, and to select your optimization objective, which is really telling the model what is your priority as a supply chain manager for where you want your staff to be placed in the supply chain. So in the case of Zambia, we weren't using the optimization feature for treatment gap or minimize stock out. So we had selected match staffing to demand. However, we foresee a potential opportunity in the future to use the 2 other optimization features. Next slide. So as an example of how the model looks, this is a screenshot taken from the model. It is the output tab. So as the user is going through and inputting that necessary data, they then will come to the output tab. And this is really where the fun happens for supply chain people. You're able to use the model to run various scenario analysis. And we really see the bulk of the work happening in that data collection, data refinement phase. So in the case for Zambia, we asked the model, given unlimited resources, that be unlimited budget to hire, unlimited capacity for talent, how many people do we need and where should those positions be staffed across the supply chain? So you can see that for our case, we were interested in the provincial hub, but in a bigger project where you're looking throughout the supply chain, you're able to toggle between service delivery points, in various levels within the supply chain. Then in the current staffing, this is for a comparison for the supply chain manager to quickly make analysis. And then in the blue header, we have the recommended staffing. So you're able to see the total amount of staffing needed or recommended, and then that breakdown between those activity categories that we identified earlier in the activity timing phase. Next slide, please. With Zambia, we then ran constrained scenarios. So as an example, we had a hypothetical scenario where we were going to set this budget ceiling at hiring 40 individuals to staff at the 4 locations. So we told the model, given the constraint of only 40 people, where is the best way to use those 40 staff across the 4 supply chain nodes. And the model will give you that breakdown, not only by the total, but also breaking it out by activity category. Next slide. So the great thing about the WAT is that it's not a one-time tool. It can be a living tool and can really embed within the supply chain strategy. So in the case for Zambia, they were having their warehouse management system go live soon after the end of our project. And we advised that once that WMS data was live, they can use the transaction data from that system to go back to the activity timing and validate those estimates, giving sharper data for the model to calculate on. Our next advice for them was to regroup with the leadership team and start thinking about the optimization features of this tool. So is there a health strategy focused on health outcomes that we can maybe look at and start measuring to run the tool again using the optimization feature of health outcomes. Next slide, thank you. So as Dominique mentioned, we've been working on this tool for quite some time, and we've been able to produce quite a bit of resources. So if this has piqued your interest at all, you can head to the PTD website or this SharePoint, and I'm sure Dominique can maybe add it in the chat. And you'll be able to find the Excel model, so you'll be able to click through the pages and play around with it. We also have a user guide that has a voiceover with step-by-step instructions. And I think also for this group, which would be really helpful, is the advocacy brief and the example use cases. So the example use cases are hypothetical scenarios where we see the tool being useful to this global health community. And I think this could be an interesting way to kind of start the conversation. Next slide, please. And in your research and from hearing this presentation, if you have any interest in maybe using this model for your staffing needs or for a project you're working on, feel free to get in touch and we can provide that thought partnership to refine the research question and really form the research question, which will then form the data collection and further analysis. And that is all we have. Dominique, any last words before we sign off?
And no, thank you, Elisa. Again, as Elisa said, if you have any questions regarding the WAT or its application in Zambia or any other countries, and have an interest in talking to us about other use cases, please do get in touch with us. You have our email address is here. There's more information on our website. I've also posted our SharePoint folder that contains a lot of the materials for the WAT. So thank you.
Thank you. That was great. We have a couple of minutes for questions. If anyone from the audience would like to ask, you can write in the chat or feel free to unmute.
Yeah, hi Gabe, and thank you, Alyssa and Dominique. I guess I have one question. You mentioned a couple times, right, how data intensive the tool is, and how kind of it requires the proper inputs to make it truly useful. And it looks like you have a lot of material to help kind of guide potential projects and users through that process. But I'm curious, how hands-on are you and your organizations in helping individuals kind of use the tool? Do you envision a time when you can really kind of hand them off a package where they'd be able to operate it completely on their own? Or do you vision it kind of like more of a partnership with you and your organizations?
I think it definitely more of a partnership with organizations. Yeah, that's as we presented, it's as you said, it's a very data intensive exercise. I think just initially there would be a need for such a partnership. But Elisa, would you, how would you respond to that?
Yeah, I think the ultimate goal is for it to be a standalone tool. But in the beginning, and because this optimization feature is newer to the community, I think a partnership model, especially for setting it up correctly to be used for scenario analysis. But I guess I would call it the training wheels approach. The goal would be to have that partnership and then slowly step back and just be available for technical assistance or thought partnership as needed.
That makes sense. I appreciate it.
We have one more question from Casey, and then I think we can move to the next presentation. It is, how handy available is the what? Does it require any specialized training skill? Can it be used in remote areas?
So yes, it can be used in remote areas. There is some specialty needed, and the materials are all available on our website, and so therefore are handy. But Elisa, maybe you can speak to what kind of specialized training or skills are necessary.
Yeah, I would say the biggest success factor is having somebody on the team who completely understands the local supply chain. And I know I feel the question was more about technical needs, but that subject matter expertise in the supply chain setup and understanding of the data is very helpful in making the rest of it really work. The model is a generic Excel model that we built, and if you're familiar with Excel, it's pretty standard. I would say it's on the scale of technical solutions and models, it's much on the easier for everyone type of model. So I don't see any issues with that. It's really more about making sure the right people have the right amount of time allocated to set the project up correctly.
Thanks, that's perfect. Yeah, I was also going to say, even though right now it is within an Excel format, the plan and our vision for the future is really that this would be built into some other sort of online software, be open sourced, etc. So that's really the vision for the tool going forward.
Thank you, Alyssa and Dominic. That was great. My colleague Tyler will share the next presentation, and I think we can push it. Yeah.
Perfect. And I believe we have a video for the presentation. The topic is COVID-19 consumable model solution for South Africa. And Ben, I know that your name is tied to that, and I believe I see you online. Would you like me to just go ahead and share the video? Anything that you'd like to say beforehand?
Thanks, Tyler. I think you can play the video and then we'll take Q&A afterwards.
Perfect.
Thanks.
Hi, welcome to the Global Health Supply Chain Summit. My name is Ben Reineke and my teammate is Jan Olofse, who unfortunately is not available to present with me today. Thanks for giving me the opportunity to showcase our work. So with no further ado, let's jump into the presentation. So we will represent abstract 8, track number 10. And as I said earlier, my name is Ben Reinecke and my teammate is Jan Olofse, and we will present the medical consumables model for COVID-19. It is important to understand and state the immense strain that the COVID-19 pandemic has put on third world countries' healthcare sectors. In the South African case, medical consumables has never been monitored closely or even forecasted or budgeted. The objective of this project was to identify the necessary medical consumables with the help of medical professionals to forecast the need to meet the required increased demand. Due to the increased number of patients presented at public hospitals, medical consumables exceeded their normal demand. We focused only on public hospitals and field hospitals in the model to ultimately provide a 3-month rolling forecast and quantification. Our approach was fairly simple. 1, we identified the medical consumables. 2, we assigned the appropriate specifications with the help of medical professionals and reliable research. And 3, develop a dynamic forecast and quantification model. So it is important to understand the different types of oxygen treatment that was needed to treat a specific portion of COVID-19 patients that presented themselves at public hospitals or field hospitals. 1, we have supplemental oxygen therapy. This treatment is recommended for patients with low oxygen saturation. And 2, in the absence of an indication for endotracheal incubation, one of the following techniques may be considered. A, high flow nasal oxygen therapy, which we refer to as HFNO for the rest of the presentation. B, continuous positive airway pressure, CPAP. And C, non-invasive ventilation, NIV. For the dynamic model, we had several important inputs, namely 1, patient data, 2, number of beds data, which was either driven by patients or the actual number of beds, and 3, the device data. For patient data, we only focused on the projected symptomatic cases, which represented only 25% in the South African case. Of that 25% symptomatic patients, only 24% was regarded as severe or critical cases, meaning this will be the patients representing themselves at public hospitals or field hospitals. Of that 24%, 92% of the patients was projected to end up in a general ward, and only 8% in the critical care or either ICU. The final split of patients in a general ward suggested that 80% will need supplemental oxygen therapy and 20% will require continuous positive airway pressure. In the ICU, 25% of patients will require CPAP and the other 25% will require HFNO, while the other 50% will require invasive ventilation. So in summary, if we divide the patient's data down to just before we reach the location of treatment, meaning a patient will either move to a general ward or an ICU, this will now indicate how many beds we need in either one of the sections, combined with the recommended or projected treatment that will happen in that bed. After scrutinizing all the inputs and possible outcomes, we realized that there is 3 possible outcomes for the COVID-19 lift projection. 1, we develop a patient model, i.e. assuming that we can treat all patients as required. The lift projection for the medical consumables was therefore mainly driven by patient data. 2, we have the uncapped beds and device model. This model assumes that all beds are occupied and all devices are utilized 100%. For the uncapped beds model, the lift projection suggested that the number of beds needed rather than using the actual number of beds at facilities. We also did not include any patient data when we did the calculation for the uncapped beds and device model. The capped beds and device model. Here we have the incorporated patient data, actual bed and device availability data. For this output, whenever the patient model output is smaller than the uncapped beds or device model, we diverted back to the patient model output since the projected lift reflected the actual need rather than forecasting the need for unnecessary consumables, which will have resulted in procuring unnecessary consumables and spending more money. Let me take you through the model now and the dashboard. Okay, so here we can see that all the input sheets are in green and the final output sheet is in black. The assumptions and input assumptions sheet are exactly as I explained in the PowerPoint presentation. When we look at the input epi projection tab, we here have three important input data provided to us by various parties. Just to reiterate the three data inputs again, we have the patient projection, we have the beds data down to district level, and then finally, we have the device data. The consumables, the consolidated consumables list is where we identified all necessary consumables, linked it with its demand driver. So over here, we can see all the different consumables with its index. We linked it to its normalized demand driver. So for example, this consumable is driven by patient numbers, where this consumable is, for example, driven by beds numbers. Then we have the usage amount. So how many of this specific consumable do we need per patient, and the usage unit of measure. So for example, this consumable, we need one consumable for the entire duration of stay. Whereas other consumables, we need to replenish every single day. We then had to link each consumable to its different locations in a hospital. So here we can see that we link the consumables to the different wards in a consumable and in a hospital. And then finally, we had to then divide the duration of stay between a general ward and ICU, because the duration of stay differs when a patient is in a general ward or an ICU, and some of the consumables are obviously linked to both locations in a hospital. After considering all the inputs, we used Power Query to consolidate the COVID lift for the three different outputs and various different scenarios. So, for example, if we now look at the patient model, example 2, we can see that we're in the ICU and we're looking at the duration of stay and the number of patients. For item MDD 13, we can see that this item is linked to the ICU and this patient will receive CPAP. The normalized demand driver is the patient numbers. The unit of measure is for the entire duration of stay. The usage amount will be 10, and then the duration of stay will be 9 days in the ICU. And we also use the epi projection data, which is the patient data. So just to explain this calculation, we then said, okay, we now take the ICU non-ventilated usage, which is 10, times the number of patients for this specific month in this province, the projected number of patients. We times it by 25% because only 25% in the ICU will receive CPAP, and that's how we got to the COVID lift projection. So lastly, I would like to share a brief overview of the Power BI interactive dashboard that we built to easily compare the different lift projections. So if we look at the Power BI dashboard now, we can see that we can now choose, do we want to be in a general ward or an ICU? What type of treatment do we want to look at? And then we can also choose the different scenarios. If we take the beds model capped, and we say the demand driver is then obviously the number of beds because it's capped, and the model description will then also be the capped beds model. And then if we then look at ICU, we can then see what is the COVID lift projection per province for the specific consumables. So in conclusion, the three different COVID lift output models enabled our client to project the consumables need down to provincial level, alternate between different scenarios as the pandemic played out, and budget monetary amounts needed to procure the necessary consumables. Thanks.
Thank you, Ben. Appreciate that. Before we open it up for Q&A, anything else that that you'd like to share or comment on?
Thanks. I think I covered everything. I was just wondering, was the audio fine? Because I struggled to hear it. I don't know if it was my internet connection.
That is a good question. Hopefully others were able to hear the audio. I know it was coming in clean on my end, but I know I was one presenting, so it may have been different for me.
Okay.
Yeah, I can tell from the audience perspective that spreadsheets are not showing clearly. They were showing, we couldn't read the text very well, but it was great to follow your explanation, and it seemed like a very comprehensive model.
Thanks. Sorry about that. On my side, when I sent it in, it was fine, but maybe next time I'll do a live presentation.
Well, awesome. Thank you, Ben. Any questions from the audience? I think we have a few minutes if there is anything pressing. And you can feel free to come off mute or put the question in the chat box, and we can direct it to Ben as well. Well, I guess I can ask one question, Ben. You know, have you felt the need to, or have you continued to kind of update the model or any assumptions in how you're calculating things as you know the pandemic has continued to evolve, or you know, has it kind of been static and really what you're playing with is more the input data?
Thanks for the question, Tyler. So at the beginning, as a developing country, it was quite a mess, the start of the pandemic. So we built this model at the start of the pandemic because of the uncertainty in the healthcare, public healthcare sector of South Africa. And I think at that stage, the model enhanced provinces to better forecast and budget the need for consumables, because as I said earlier, we've never budgeted or forecasted for consumables. But I think as the pandemic played out and is still playing out, I think provinces started to develop better capabilities of dealing with procurement and budgeting and forecasting. But the model is also very easy to update. So if you receive updated EPI or EPI data, you can just dump it into the Excel input sheet, press refresh, and then the dashboard would update as well.
Awesome. Yeah, very, very powerful, definitely.
Thank you.
All right. Oh, sorry, go ahead.
Yeah, I have a question as well. Regarding the input data for the model, I have some experiences with health system data from Brazil, where I came from, and sometimes it's very hard to get structured data. And so I'm curious about how you manage that, getting all the data that you needed to build the model and to keep it updated as well. And if you have some, knowledge on that.
Thanks for the question. Yeah, that was a very, very difficult task because, as I explained, it was data inputs from different parties. So the EPI data was quite easily to find, but the actual bed data and the consumables data was really difficult to get hold of. And that's why we only had that data down to district level, because it's impossible to have the number of beds and the number of consumables down to facility level in South Africa. So the data was quite difficult, but after we received the data, it was quite easy to build the model and to make the predictions.
Thank you. Yeah.
All right. If there are no other questions from the audience, I think we can move on to our final abstract for the day. Thank you again, Ben, for sharing your work. Much appreciated. Okay, and then the last abstract we have for today is strengthening public health emergency supply chain system, the implications of COVID-19 response in Uganda. Do we have Irene or Henry on the call? Just wanted to make sure that we have somebody representing the abstract before I share the video.
Yeah, I'm around. Henry's available.
Perfect. Thanks, Henry. Anything you want to say before we share the video, or should we just dive in?
I mean, we could dive in and just probably discuss after that.
Perfect.
Welcome. We're continuing with the look at the approaches and methods to improve health supply chain systems. Specifically for this abstract, we are going to look at the approaches towards strengthening the public health emergency supply chain system in Uganda, with a specific focus on the implications of COVID-19 in Uganda. So basically, what was the impact of COVID-19? How did the country respond in terms of building the public health emergency supply chain capacity? My name is Henry Owundo. I work with the USAID Strengthening Supply Chain Systems activity in Uganda with Management Sciences for Health, but I also support Ministry of Health directly in the Logistics Subcommittee for COVID-19 response. You're welcome. So, in terms of an overview, we'll look at the impact of COVID-19 on Uganda's health supply chain system, and looking at the broad strokes of the elements that are critical for the supply chain system to be responsive. We'll look at the challenges that COVID-19 brought to the system. We'll look at the key actions that Ministry of Health and the COVID-19 Logistics Subcommittee adapted to respond to the change in demand. We'll also look at the key actions that that surround really the logistics management information system. As you shall see, this was a critical issue for Uganda's public health emergency supply chain response to COVID-19. In conclusion, we'll look at the key achievements that have been registered over the response period, and we'll look at the lessons learned as Ministry of Health and the key actions that we propose moving forward. So COVID-19 has challenged the health supply chain system in Uganda, as it has done to all health supply chain systems across the country, the world. So, but what it has also done is highlight the critical role of having a responsive and robust public health emergency supply chain system. In Uganda, the impact has been seen in several ways, including long lead times of up to 60 days. It has been seen with the challenges in coordination of partner resources, both in terms of commodities that are donated, but also the finances that are made available for the response. The challenges have also been seen in terms of the limitations in capacity to track commodities from the warehouses up to the time they're dispensed at the user points. Challenges have also been experienced in terms of the use of paper-based systems in terms of for ordering, and this has also resulted in long approval processes. So at the base of this all was a big challenge in regards to the lack of a dedicated logistics management information system, specifically an electronic logistics information management system that would allow data visibility across the chain. So for this abstract, we're going to look at the key elements that are critical for having a responsive and robust public health emergency system. And what we also looked at the challenges and the gaps that were realized because of COVID-19. And also, so what is clear, looking at the diagram that is before you now on your left, is that there was a critical interest towards improving the health information systems, because this influenced forecasting, it influenced the capacity to procure the right commodities, distribute them to the right people at the right times, and it also influenced the capacity to source for resources to meet these demands. Ultimately, lack of a dedicated information management system affected the capacity of the Ministry of Health to reach and cover the population that required these commodities. So in response, Ministry of Health, through the Logistics Subcommittee for COVID-19, continued the work to develop and complete the Uganda National Medical Countermeasure Supply Chain Plan. This supply chain plan contains critical standard operating procedures for the Logistics Subcommittee, including details on quantification of commodities required for the response. It also contains guidelines for managing medical countermeasures at the health facilities. These are the user points where the treatment happens. And finally, it also contains national guidelines for the National Drug Authority in terms of managing commodities during a response. We are also expanding now to the Uganda National Medical Countermeasure Supply Chain Plan to include aspects of human resource deployment. And all this is as a result of the COVID-19 response. As we have seen, one critical element that the Ministry of Health needed to act upon was the logistics information management system. And in this regard, the existing emergency electronic logistics inventory management system was expanded to cover COVID-19. This had the effect of allowing for real-time data visibility, and this supported decision-making in terms of moving the commodities to where they're most required, but also allowed the subcommittee to prioritize commodities as well, which were the most urgently needed. It also allowed for electronic ordering, reporting and accountability of supplies, but furthermore, it allowed for mobilization, visualization, and coordination of partner support. Other critical actions that the Ministry of Health took include strengthening the human resource at the different levels, the national and subnational level, on key aspects of public health emergency supply chain. This includes aspects of coordination and management of commodities, as well as information and commodity flow throughout the supply chain system. Ministry of Health also moved to conduct a public health emergency supply chain simulation exercise. And this was done to test the functionality and responsiveness of the emergency supply chain systems. With this simulation activity, Ministry was also able to identify the gaps with the proposed public health emergency supply chain system and make critical adjustments to improve the system. So in terms of achievements, what Ministry of Health has realized in the last period of response is that one, we now have a weekly COVID-19 stock status report that highlights stock levels at national and subnational levels. This report is discussed at the coordination meetings that are held on a weekly basis and discusses the key observations and actions that are required to be taken to ensure that commodities are available at the user points consistently to meet the demand. So from this, we're also seeing that the number of health facilities that, and I must specify, we're looking at the treatment units, providing accountability reports for commodity supply, which has now grown to 90%. The baseline for this is 0 because, like I said, we did not have a logistics management information system. In terms of availability, there has been a growth of about 88 to now 88% in the percentage average commodity availability at the treatment units. This has grown. This is a growth from 67% in the last 6 months. Furthermore, we have also seen that from the data that we have been able to collect, the Ministry of Health has realized about $68 million in funding from Global Fund alone for the COVID-19 response. There's additional funding that has also been realized from partners, including USAID as well. The government of Uganda has also provided funds, also based on the data that the Logistics Subcommittee is able to provide. In terms, looking at more specifically in terms of the stockouts, we see that at the designated treatment sites and the testing sites, we see that about 94 and 85% respectively of the treatment and testing sites are reporting no stockout of the respective commodities. That's a huge milestone for Uganda's response, and we're moving forward to ensure that that we have 100% no stockout rates. In terms of coordination, the Logistics Subcommittee partner warehouses, we see that 71% of the warehouses that are supporting the response have their data in the logistics information management system, and we are now able to account and coordinate the movement of those commodities at those warehouses, in addition to the national medical stores. So on your right, you can see an excerpt of the COVID-19 emergency success report that I highlighted earlier. And this report looks at about 17 tracer commodities and highlights the stock availability at the national level and the subnational level, with critical action areas in terms of ensuring that commodities are available, that we are responding to the priority items, and that we are responding to the orders that are coming in from the subnational level and from the user point specifically. So moving forward, what we have learned, we see that COVID-19, of course, presented challenges to the health supply chain system in Uganda, to Uganda's public health emergency supply chain system. However, we see that it provided us with opportunities to strengthen the public health emergency system in Uganda, as we have highlighted. So what we're seeing is that for an effective and responsive public health emergency system, there are critical areas that we have highlighted below. We see that it is critical to strengthen coordination and and human resource capacity of the supply chain staff. We see that it is critical to strengthen and invest in infrastructure and systems support information flow and use in the management of public health emergency commodities during the pandemic, but also in the preparedness phases of the pandemic. I must highlight that as well. So having a responsive LMIS is critical to bridge the gap between the national and subnational levels. We also see that it is critical to strengthen collaboration between supply chain stakeholders so that we can build a holistic solutions of public health emergency supply chain system. So with this, you are able to leverage on the varying strengths and capacities and ensure that there's efficient resource allocation and furthermore utilization. Thank you very much.
Awesome. Thank you, Henry, for that. Anything that you want to add or expand on before we open it up for a quick Q&A?
Yeah, can you hear me? Yeah, I think what is important, I think, is that when a pandemic strikes, there is a lot of excitement that comes with it. But what we are learning is that it's the response can be organized. It can be very well coordinated if you have the information, if you have the key players in one place. So for us, that's a very critical learning that we have from this response. That data is critical. I think that every speaker has spoken about throughout the summit. But having a very, what I would say, a responsive information system that is agile and dedicated to the response is a very key part of that. It allows for coordination and prioritization of resources that always become available during the response. I think that's probably one thing I just probably want to say. Thank you.
Thank you, Henry. We'll open it up for a few minutes for Q&A from the group. Again, feel free to come off mute directly or put a question in the chat box. And perhaps while people are thinking on that, Henry, I can kind of open with a question. So, and obviously, in kind of your point that you hammered home after the video as well, right? The information and data is key in kind of operating a responsive supply chain. I'm curious that in addition to data on stockouts and kind of areas to prioritize, did this effort kind of unveil any other kind of infrastructure needs or areas for improvement in kind of the flow of goods as well in the supply chain? I'm sure that having all this data probably opened up some opportunity to kind of identify areas where you could improve not only the flow of information, but the flow of goods as well.
Let me see if I can answer that correctly. But recently, of course, there have been developments in the oxygen space. Recently, of course, there are challenges with oxygen supply. And then also, there's also issues with vaccines as vaccines become more available. So we're looking to make sure that that we have a system in place where the provision of vaccines, especially oxygen, especially supplementary oxygen, which cannot be produced at the places where it's required, is more proactive, as opposed to waiting for the need to be generated. So we are realizing that there are some items that you need to be more proactive and just go by the metrics in terms of usage, as opposed to requiring ordering. For vaccines, we're also exploring, of course, issues of pre-registration. Again, so I think what is from this whole thing, I think, yeah, definitely we're exploring so many other avenues that have resulted from this other response. And I hope I've answered the question anyway.
No, you absolutely did. It's it's just kind of interesting to see that once you kind of have some of this data, the other opportunities that you're able to identify and execute on. So I appreciate sharing some examples of that. Any other questions from the group? Okay.
It's a quiet day here. Yeah.
Yeah, day three of a long but exciting conference and summit. So, well, thank you, Henry. Appreciate you sharing those insights and all that information. Gabe, I will hand it back to you. I believe there might be a little bit of a break before kind of the closing thoughts, but we'll let Gabe
Yes.
kind of provide that info.
Sure. So we will get back together at 12:35 for prize winner announcement, other announcements, and closing remarks by Ravi. And then followed by opportunity to network at 1 p.m. Eastern time. So it's about 20 minutes break. So thank you all for coming, and it was great to have you. Don't hesitate to reach out if you all have any questions.
Thanks, everyone.
Thank you.
Thanks, everyone.
Yeah, cheers.